Hello, and welcome to The Two View, the cutting-edge educational show for PAs and nurse practitioners in emergency medicine and urgent care. This is our 50th episode. Welcome, welcome, welcome to oldies and goodies as well as newbies and nosies. And I'm Martha Roberts. I'm an emergency medicine NP and assistant professor in Northern California. I'm here with my not yet 50-year-old friend, Michael Sharma, PA. Hi, Mike.
Not yet. Don't put that evil on me. That's right. My name is Mike Sharma. I'm a practicing emergency medicine and urgent care PA in the Dallas, Texas area and an adjunct professor of PA studies. And I just got back from Orlando, Florida with some, actually an NP and a PA colleague of mine. We just got done teaching some procedures there, your favorite procedures with physicians, PAs, nurse practitioners. And whenever I teach and whenever I podcast with you, Martha, I'm reminded both of how far we've all come in our practice of emergency medicine and sometimes how far I have yet to go. I've been doing this for 10 years now, emergency medicine specifically, and I still feel like I'm just getting started. All right, well, you know the drill. It's time for our first segment, The Wet Read, where Martha and I get 60 quick seconds or so to talk about something that caught our eye.
Yes, Mike, this one is always my favorite. And today's literature spotlight is nurses over 50. Are you recognizing the theme? This is why nurses over 50 are an absolute powerhouse in healthcare. A review in the Journal of Nursing Management from 2016 looked at experienced nurses' contributions and found that despite facing higher rates of musculoskeletal strain, fatigue, and so many other more crazy issues that they face, nurses in this age group are often outperforming their younger peers in clinical decision-making, patient communication, and error prevention. Wow. Decades of pattern recognition translate into faster, safer interventions, especially in high acuity settings like the ED, and they are experienced and they are seasoned. It turns out 50 is the new 30, but here's the catch. Retention is tricky. The same paper emphasizes flexible scheduling, mentorship roles, and ergonomic workplace adaptations as key strategies at keeping this skill set in the workforce. In other words, investigating these nurses over 50, it's not a charity, it's a strategy. And they're not just carrying the torch, they're keeping our lights on. I like this paper because they combine the warmth of human stories with policy analysis, conducting focus groups and interviews with 46 nurses over 50, and reviewing flexible working policies. Close your eyes and imagine a nurse weathered by decades of trauma, triumphs, and textbook blurs. She asks not for a gold watch, but for a shorter shift, daytime hours, and some applause. The policy exists, but the system forgets to pass the mic. We can do better for those that have done their best and are still outperforming our newbies.
That is really interesting. And yeah, hats off to the nurses that have been getting it done for decades. I feel like, and this could be a whole other segment, but you meet young nurses coming up and they've had about 5 minutes of bedside experience, and you ask them hey, so what are your plans? What do you want to do? And a lot of them oh, I want to become a nurse practitioner. I heard Psych NP is real hot right now, or I could become a CRNA. And I wish, and this is a problem they're still solving honestly for NPs and PAs, but I don't think they've solved this problem yet for how can, you're saying, how can a bedside nurse stay bedside for 30, 40, 50 years and still have it be a meaningful career, still have it be something that's sustainable? I would love for us to get that way because we can't lose that bedside experience. We really need it. The new clinicians need it. I need it. We need those patients at bedside taking care of the nurses rather at bedside taking care of patients. So full support. Well, imagine a world where the diseases nobody talks about, those lurking in the tropics, neglecting, overlooked, finally got their day in the sun. In 1975, the World Health Organization unveiled the special program spelled PROGRAMME, so you know they're serious about it, for research and training in tropical diseases. That's abbreviated TDR. Backed by UNICEF, UNDP, and the World Bank, TDR became a global lab of collaboration, shining a spotlight on illnesses like leishmaniasis and river blindness. It didn't just open doors, it built new wings and research hubs across countries where the disease actually lives. Decades later, 5 of the 8 original target diseases are on the brink of elimination. That's amazing. That is structural historic change anchored in things like equity and curiosity. TDR reminds us that solving these weird diseases is not a footnote in history. It is a foundation of global health justice and just not letting popularity drive how we treat diseases. Within the early years, TDR seeded this long-term institutional grants, individual training opportunities, and so now institutions that were not on the forefront of research are now really turning out research articles, publishing more, collaborating regularly and internationally, and even earning competitive grants. We thank you, TDR. And some of you may be thinking like, well, what good are things like tropical diseases to me in, let's say, urban Dallas, urban San Francisco? We've diagnosed patients with malaria. We've diagnosed patients with dengue fever. We've diagnosed patients famously with Ebola virus here in Dallas. And so these tropical diseases do not respect boundaries. If a plane can get you here from there, or a boat or anywhere, then you can diagnose these places on your very next shift. So thank you very much, TDR, and we are reaping the benefits 50 years later.
All right, so let's do a quick plug for our upcoming course. There is still time to register. If you are hearing this, there is still time to register. For our boot camp, go to www.ccme.org and register for our original boot camp November 4th through the 8th at Planet Hollywood in Las Vegas. We do have some pre-courses still open, but I doubt they're going to remain open when you're hearing this, but you can try. Please just check. And we're going to give away 1 ticket to a seat. Stay tuned to the end of the show when we tell you who it is.
I've been looking forward to this. I have mentioned previously that Kelly Clarkson is going to be having one of her residency concerts while we're there during this boot camp. Tickets right now are like $400, $500 a seat. So if you know Kelly or you happen to have a spare ticket for that week, Hook a Podcast up if you don't mind. Love to go.
Why would they go see Kelly Clarkson when they can hear me sing on this podcast?
Yeah, I mean, we could definitely do dueling pianos. How about that? We could get you set up at the Paris. They have that dueling piano bar. We can do a little, Elton John, Billy Joel, you and me kind of a thing going on.
I mean, for real, everybody just wants us to get to segment 2, so here we go. All right, next is the dry scan, where we penetrate a little deeper into 2 other topics. And whoa, do we have something for you today. Mike, let's start off by going fishing. I can tell you one of my favorite things to do with my father growing up was to go fishing, and we would take trips to Maine and Canada. And one of my most memorable experiences involved launching our boat off of the train tracks. We had to hoist it up, push it a half a mile, and then take it down into a private lake. Only moments later did a train come, even though the guides promised us that it wouldn't. But I want to talk about going fishing for things in the emergency department, and we all know we do it, and we all know we've tried to figure out difficult cases and zebras amongst the horses.
Yeah, whether it's Stevens-Johnson syndrome or Fitzhugh-Curtis syndrome, I agree. There are many syndromes and other things that we do in the ER that can be seen maybe either just like we're really trying to force a round diagnosis into a square peg here when we really kind of latch onto a diagnosis. But when you do find that weird, rare disease, it is so satisfying for, well, I don't know about the patient, because no one wants to be the most interesting patient in the ER. It's at least satisfying for me.
De Crevaine's tenosynovitis is your diagnosis. I love that one. Anyway, we call that the big fish, Mike, where I come from. And I want to talk about a question that we not only get at our courses, but we've had a few emails about people writing in about this recently, among other tests that we do. And I want to address for our 50th episode. Let's talk about BNPs and D-dimers in the ED. When are we just fishing?
Oh man, I still have this case in the medical legal literature. It was just the Scott Weingart from Emcrit just put out his opinion on this interesting case. He has it on his podcast, full free episode. That's not usual for Scott, but for this one, he has a full free episode because of it being such a really pivotal case when it comes to diagnosing a PE in a poor gentleman who had a bad outcome, and the road to hell, as Stu Swadron says, is paved with BNPs and D-dimers. We all have to admit BNPs and D-dimers are two of the most overordered, misunderstood blood tests in the ED. And, they're often ordered, quote, like just to see when a patient is short of breath, has chest pain, or has some sort of other weird complaint that could be chalked up to CHF or PE. The evidence tells us they only helped when we've asked the right question before ordering these tests.
It's always about the right question. So let's talk about what the BNP actually is and what it's good for. Sort of like my ex-husband, just kidding. Okay, remember the B type natriuretic peptide and its cousin NT-proBNP is released from the ventricular myocardium in response to stretch and volume overload. Looking at this test from an evidence-based role, the BNP can support the diagnosis of acute decompensated heart failure as well as trend interventions to treat it, especially when the diagnosis is unclear after history, exam, and chest x-ray. I want to draw your attention to a study in the New England Journal of Medicine by Maisel et al. Back in 2002. This was entitled Breathing Not Properly. I love that.
Oh, because BNP. For a second, I was like, why would you call it that? But okay, I get it now.
Don't you just, we can be funny in healthcare.
Full
Anyway,
support.
why did they do this study? And how did they do it? So they enrolled about 1,500 patients who were rushed into the ED with acute shortness of breath, and the BNP levels were measured on the spot while two cardiologists, completely looked at this blindly. At the BNP results, they reviewed the patient info to establish whether congestive heart failure was indeed the culprit.
Here are the results of this study. Out of the total, 47% of patients were ultimately diagnosed with CHF. 5% had dyspnea due to non-cardiac issues, but had a history of left ventricular dysfunction, so there's that. And the remaining 49% had absolutely no congestive heart failure. Number next, using a BNP cutoff of 100 picograms per ml, the test's overall diagnostic accuracy was 83.4%. So that's not too bad. If BNP was below 50 picograms per milliliter, the negative predictive value, meaning the test's reliability for ruling out CHF, soared to 96%. So much more helpful as a negative predictive test than positive, as you're hearing. Even after adjusting for other clinical factors, adding the BNP measurement significantly improved predictive accuracy. So, yeah, it can be helpful, but you got to ask that right question first.
Right. Mike, why does this matter? I'm a little choked up here, not because I have heart failure, but because I'm choked up about our 50th episode. But why does this matter? Shortness of breath is a classic detective case in the emergency department. Your heart failure is your big suspect, but so are lung issues and other mischief makers. BNP offered an efficient truth serum to confirm or rule out CHF with swift results that outperformed traditional signs, symptoms, and labs alone. It helped fine-tune decisions, speeding things up or slowing them down thoughtfully and improving clarity. Imagine the ER as a weird carnival mirror maze. Symptoms like dyspnea distort the truth, making it hard to see what's really behind the glass. BNP is like a neon sign that cuts through the distortion, guiding you toward heart failure or something else. Not perfect, but far more illuminating than groping around in the dark.
So, to summarize, adults with acute dyspnea with rapid bedside BNP testing greater than 100, this can help accurately diagnose heart failure in about 84% of patients. Like we said, BNP under 50 virtually ruled out heart failure with 96% negative predictive value. That's almost considered a full rule out. There's still 4% there, though. There is some degree of acceptable miss rate in medicine. It's closer to 2%, but 4 is close enough. The BNP added unique diagnostic power beyond clinical assessment. But don't be fooled, because the BNP is not some sort of mystical oracle. It's a logical boost to emergency diagnostic thinking when you're worried about matters of the heart.
The BNP is most helpful in, quote, the gray zone, we like to say. These are our obese patients, those with COPD, or when the chest x-ray is equivocal. It is less useful in clear-cut cases or when there are confounding variables such as age or renal failure, sepsis, pulmonary embolism, because all of those things can elevate the BNP without congestive heart failure. Okay, so possibly you can consider ordering the BNP if you wish to trend it or do something about it. The bottom line here is don't use the BNP to rule in heart failure when you already know the diagnosis. Use it to clarify uncertainty, and if the result won't change your management, then don't order it. Okay? Let's talk about 2 cases now, Mike. I'm going to have you go over case number 1.
Okay, case number 1, you're in the middle of a busy shift and a 72-year-old woman rolls in with shortness of breath for 2 days. I imagine she's rolled in like a wheelchair and not like literally like rolling down the hall. But
she rolled in with her homies, okay?
Okay, gotcha. She's got a history of COPD and CAD, coronary artery disease. Chest x-ray is a little hazy. Could be some atelectasis. Could just be scarring from 72 years of living on this earth. Maybe it could be CHF. There's a little bit of wetness in the lungs, but there's also a little bit of a wheezing sound in the lungs. A little bit of hypoxia, but if you got COPD, not unusual to have a little bit of borderline low 90s SpO2. She's not crashing. So you make some considerations, you weigh your options, and instead of just pulling the Lasix trigger or furosemide if you're nasty, you decide, let's get a BNP. And it comes back at 1,200 picograms per ml, significantly above the normal cutoff and higher than her baseline 6 months ago. You look at the chest x-ray, you see, there's some cardiomegaly. That's a really important thing to look for, by the way, your chest x-ray. Cardiomegaly, if you're thinking somebody has some ventricular hypertrophy that usually goes along with CHF. You've got those crackles, and so you put it all together and you lean towards a diagnosis of acute decompensated heart failure rather than something like a COPD flare. So with that information tucked away, you start those diuretics. Lo and behold, the breathing improves, and she avoids things like steroids or antibiotics. This is where the BNP works at its best. She's got a little bit from column A, a little bit from column B, and you're not quite sure where to go. And so when you get that BNP, you kind of try to rule out confounding factors like, hey, wouldn't be surprising if this person had some kidney failure or what have you, some end stage or some chronic renal disease. Rule those things out, pull a BNP, and this is where it shines, answering a clear diagnostic question when the picture's a little bit blurry.
Right. So teaching point here, Mike, is the BNP shines in diagnostic gray zone, of course, when the diagnosis is not obvious. But, Mike, I want to talk about case number 2, ordering the BNP badly. Okay? So this is case number 2, BNP ordered without a question to answer, the key here. It's 2 a.m. and a 40-year-old man comes in with chest pain that started while he was playing basketball. No shortness of breath, no orthopnea, no edema. Vitals are rock solid. Oxygen is 99 on room air. He's fit, no cardiac history. For some reason, a BNP is ordered along with troponin and labs. We know how that goes in triage, right? And it comes back mildly elevated, 180. Now, the team starts wondering, does he have undiagnosed heart failure? Okay, so now an echo gets ordered, which is normal. Turns out that the elevated BNP was probably from the intense exertion that he'd done earlier and some mild dehydration. But that unnecessary BNP created diagnostic noise, anxiety for the patient, extra cost, delay in discharge, all without really helping answer the real clinical question. In the end, his pain was musculoskeletal. That BNP never should have been drawn in the first place.
So the teaching point I think you're trying to get across is that BNP is not meant to screen this 40-year-old person who otherwise has no big medical issues. You're not using it to screen for heart failure. It's helpful to confirm heart failure when we're kind of unclear with the diagnosis and the clinical picture is a little bit worrying. But I want to posit something to you, Martha. You mentioned about ordering it in triage, and we've kind of mentioned this concept before in previous episodes, right? I often will screen a patient when they come in and then off to the waiting room with ye for 3, 6, 9, 12 hours. And so when you have a lot of time between ordering tests and disposition, and especially if you're not the one actually dispositioning the patient, I want to put it to you that maybe you kind of do benefit from over-ordering a little bit so that when the person comes back finally to the ED at hour 6, 9, 12, the next clinician has every single thing they need, because people decompensate in the waiting room, right? Stories can change, or the person can say, oh, yeah, actually, you know what? I texted my mom, and my mom said that I have a history, like my dad had a history of early heart disease and heart failure. And so, as much as I do agree, if you are the one deciding what to order for this patient and you're about to discharge them in the next hour or two, then I think it's reasonable to not order the BNP. But my eyes have really been open to where a little bit of being liberal with ordering tests when there are long wait times, I've seen how that can be very helpful. So pay attention to what's going on in your neck of the woods and act accordingly.
So somebody gave me this balloon. It says, thanks for all that you do. It was actually a student of mine. Really appreciated that. And that's basically what I say to nurses when they order BNPs that are inappropriately ordered. Thanks for all you do. And I do appreciate it. So, I think these are always great add-on levels that we can do that come back relatively quickly. And another final thought on this, Mike, is that I'd like to review when BNP helps the most. When clinical picture is murky. So if you're really in that situation where something is super murky, that's fine. The borderline case. The patient has, like you said, risk factors, mild edema, bibasilar crackles, but the chest area looks borderline and they don't really fit neatly into CHF or COPD. The multi-morbid patient, like COPD, CKD, hypertension, CAD, all in one patient. BNP might help you tip toward something else or towards the CHF diagnosis. So early arrival, the patient is still normal per se on arrival, but then all of a sudden they have this rapid worsening type of symptom. I mean, sure. Can this give us a clue before additional imaging or an echo rolls in? Yeah. But if you order this, no one's going to hate you. Just letting you know, I don't hate you. Thanks for all that you do. Balloon. That's really good for an audio podcast, but it's great, but much better for the video podcast. We'll talk about that later on, how you can reach us and watch us in the video. So when can BNP mislead you? As a reminder, it can kind of give us too much information in situations like renal failure. Impaired creatinine clearance will raise BNP levels or I guess more like clearance of the BNP rather. I'm sorry. Impaired BNP clearance will raise levels even without CHF. Older patients are tricky. BNP can run higher at baseline for them. Other serious conditions like sepsis, pulmonary embolism, pulmonary hypertension, all these things due to right ventricular strain. Now, you can look for that on an EKG and get a feel for that, but all those things can raise BNP because of that strain process. And then lastly, kind of a twist, obesity. Your BNP can be falsely low in your obese patients. So if you have somebody who looks like heart failure, walks like heart failure, very slowly, I'm guessing, with edematous legs, but they don't have a high BNP, you want to consider, hey, maybe everything else is looking like heart failure. Could the obesity be steering me wrong here? Right. So, I don't want to beat this to death, but this is why the BNP is best used as part of the overall picture and not as the number one diagnosis tool or diagnostic tool. So I think that each hospital has sort of like this age-adjusted cutoff thing for multiple lab values, which we'll talk about later for our second issue, which I'm not going to tell you at the moment, but I would guess you could probably guess what the next lab value is we're going to talk about. But I think at the end of the day, the diagnostic performance of this test is really paired greatly with your clinical physical exam and your impression. So you're looking at history, you're looking at the overall picture, and you're looking at the patient in front of you. So use it appropriately.
Yeah, and vice versa. If this person has like a known history of heart failure, they've been off of their diuretics for a month, they just got back from the state fair and ate everything that was fried or full of salt, they checked the chest x-ray, they're soaking wet like they've been out in the rain for a week, then, BNP is not going to change your plan. You kind of know what's going on here. You order the diuretics, you arrange for, potentially an admission to the hospital with TSF exacerbation. You don't have to get the BNP in those situations where the situation is more clear. Where it shines is when you are not clear. Think about it as your tiebreaker, when you're not quite sure and you're kind of caught between a couple of important diagnoses. Start with the story. Think about when it started. Did something trigger it? Maybe non-adherence to medications or other changes here. Is there orthopnea, changes in your dyspnea with position? Maybe they even have PND, paroxysmal nocturnal dyspnea. They wake up gasping for air in the middle of the night. Now, that could be a feature of asthma, so just be careful with that. Then you look and listen. Do they have rails? Do you say rails or RALs?
Rails.
Rails, JVD, which is the descended neck veins, edema, increased work of breathing. Check them legs out. Squeeze the belly if they've been laying on their belly for their back for a long time. Look for that edema. Get those basics. If somebody's having, dyspnea or chest discomfort and they're sounding cardiac, I order an EKG and chest x-ray and don't think twice. Even if they're not sounding cardiac and they have a chest pain, I'm ordering the EKG and the chest x-ray. And if they're really huffing and puffing, maybe even a VBG. Start with that, and you can go to ABG if you want to. Finally, after that, consider adding the BNP if things aren't quite clear after you get a history, after you get a physical exam done, and then you're always treating the patient. You don't treat BNPs, you don't hospitalize BNPs, you don't discharge BNPs, you treat patients. And so you gotta take the patient as a whole. Look at that BNP number in the context of the patient, and don't let one funny number totally throw you off your plans if everything else is looking like it's going to go in a different direction.
As my favorite cardiologist, whose name I won't say, told me, Martha, your lab values are bullshit, okay? What do you see on your physical exam? And that is the diagnosis. So I'm just saying, you can choose wisely by looking at the ASAP guidelines. That's great. But honestly, what is your exam showing? This is a clinical diagnosis in a lot of cases. And really good cardiologists, really good primary care doctors, really good primary care NPs and PAs can see this right away. They can also sift out you said something that doesn't quite make sense, so I'm worried about something else issue. Not to mention, we always forget about the unneeded cost burden of all these tests that we order and why. So anyway, Mike, not to be, more, I almost want to say like depressing. Is that like a bad thing to say about this? I feel depressed.
Diagnostically depressing. How about that?
I'm diagnostically depressed because, but I don't want the listener to be depressed. Get excited. Let's be positive. Let's be positive about D-dimers. So now we're going to move on to D-dimers, knowing when and how to order. So let's take it away, buddy. Oh, wait. What is a D-dimer anyway?
Yeah, I prefer to be negative about D-dimers, honestly. I hate it when they're positive. Anyways, good D-dimer humor. A D-dimer is a small protein fragment that appears in the blood when your body is breaking down a clot. Here's how it goes. You clot, and fibrin, this protein, kind of creates this mesh to trap blood cells so you stop bleeding. But that clot has to go somewhere eventually, and so when your body starts dissolving the clot, plasmin, an enzyme, starts snipping that fibrin into pieces. One of those pieces is the D-dimer. These are really important points with the D-dimer. It is just a marker for clot breakdown. It doesn't tell you that you have a clinically significant thrombosis somewhere. A D-dimer doesn't tell you where the thrombosis is. It doesn't tell you why It's there, just that there has been recent clot formation and clot breakdown. And it's most useful, just kind of like the BNP actually, in rule-out testing. In the ED, a negative D-dimer can help rule out conditions like DVT or PE this is very important by the way, in low-risk patients, saving them from getting lit up in the CT scanner or getting an ultrasound. And most importantly, it's very non-specific. Just because you have an elevated D-dimer doesn't mean you actually have a clot. Infection, inflammation, surgery, pregnancy, cancer, trauma, or just being old.
Sucks.
No, present company excluded, can raise the level. So a positive result isn't proof that there is a clinically significant clot somewhere in the body.
Yeah, so Mike, we ask, how is this supposed to be used? The D-dimer shines in ruling out a clot in low to intermediate risk patients. And I just want to say, if you think it's a PE, their pretest probability is high for having a PE. We'll cover that in a minute, but just scan them. Don't order the goddamn D-dimer, okay? Don't do it. I mean, this is a Ken Milne caveat, so.
I think we get one more swear before we come in our podcast.
Sorry.
The workflow typically goes like this. Start with a risk assessment, and this can be a tool like the Wells score. There's a Wells score for a DVT and PE. There's like the years algorithm. I think there's even the Geneva scoring system. These all kind of assess your risk for, hey, how likely is it that somebody has a thrombosis, a significant thrombosis? And then you can even further utilize what's called, if we're worrying about PE, you can utilize what's called the PERC. PERC is a really important thing that you only use, again, kind of like a D-dimer. You only use PERC when the person is low risk for a PE. If they are medium to high risk, PERC's off the table, can't use it. If we're still thinking the pretest probability is low or moderate based on your scoring systems, and by the way, it's important you talk to your colleagues in your ED. What do other colleagues do to evaluate and to assess risk for PE? Learn what's going on in your system so that you can kind of be falling in line there and not being an outlier. If the pretest probability is low or moderate, order that D-dimer. I get a little heartburn even saying that. If that D-dimer is negative and they are low risk or moderate risk, then there's probably not a clot. You can stop there. You don't need to do a scan. However, if they're lower moderate risk for thrombosis, the D-dimer is elevated, you've kind of bought that patient some imaging. And that could be something like a CT pulmonary angiogram for PE. That could be an ultrasound for DVT. Maybe it's even a VQ scan in certain conditions. The idea here, Martha, is, you don't order a D-dimer for every single person with an aching leg or an aching chest. You don't order imaging for every, atraumatic swollen leg or chest pain. You really want to have that clinical question that you've asked well beforehand, like you were saying for the BNP.
Yeah, Mike. So, like we said, the D-dimer is super sensitive, but it's not very specific. So remember, when you guys are looking, I tell my students this all the time, when you're looking at evidence and the reason behind why we do tests, why we use guidelines, why we use algorithms, is there's a lot of times that these particular tests are very sensitive, but they're not very specific. So if you go into that patient room and you're like, oh, I'm worried about X, Y, and Z because this patient is short of breath. Well, do they just have an asthma exacerbation? Are you really going to perk this person out? No, you're not. This is an asthma exacerbation because sometimes those D-dimer tests can be super sensitive, but not very specific. So what I really want you to do is think about why you're over ordering possibly the D-dimer. If you skip the risk stratification step and just shotgun D-dimer on everyone, you're going to drown in these false positives, especially in older adults, pregnant patients, people with infection, inflammation, trauma, recent surgery, or cancer. And you don't want that. I mean, I want you to take a step back and look at your whole clinical picture. And is this D-dimer really the right test? Or is it kind of like this Band-Aid to give me an hour to suture this guy's face and see what this D-dimer comes back for this other patient so I can figure out what to do then. No. So you got to use it appropriately, Mike.
Yeah, if you get a positive D-dimer, you're probably going to do CT scans or some sort of imaging. That's a lot of radiation to somebody. That's going to increase their ED stay. They're maybe going to get some incidental finding from the CT scan, like, hey, good news, no PE, but, oh, we found some interesting pulmonary nodules, and now they're on the hook for a repeat CT scan 3 months later, even though they're low risk for some sort of neoplasm, right? So tests can buy us more tests, sometimes. These D-dimers further are a little tricky because there's different kinds of D-dimers out there slightly, and then each D-dimer has a different cutoff slightly. So you really got to be aware of what you're doing when you order a D-dimer. And if you're using the standard cutoff and you're going with fibrinogen equivalent units, FEUs, you want to go for about 500 nanograms per ml. But there are other, again, kinds of measurement units out there. Okay. There's also age-adjusted cutoffs. You can take the patient's age, multiply by 10 if you are over 50, your patient is, by the way. And that has been validated in the ED to safely reduce unnecessary imaging in low-risk patients above the age of 50. There are other algorithm-based cutoffs like the years or the PEG-ED tools that can be used differently in certain scenarios. Now, I want you, some of you, and I get it, like I understand the thought process here. Some of you who are new clinicians that are kind of new to the game are like, well, look, I just want to be really thorough. And I just want to make sure I don't miss a PE. You're going to miss a PE. You play this game long enough, you roll the dice enough times, you're going to miss a PE. But I want to put something to you, right? Our body naturally breaks down clots. That's why we get D-dimer elevations in the first place. There are certain non-significant pulmonary embolisms that our body is going to break down with time anyways, that won't need to be put on things like anticoagulants. But let's say you find, you throw a Hail Mary, you get a D-dimer, oh my God, it's elevated, do a CT scan, wow, we found a itty-bitty, PE, let's get them on some sort of anticoagulant. Who's to say this person doesn't get into a car accident and they bleed to death because they're anticoagulated? They fall down some stairs, they have a head bleed that's worse because they're anticoagulated. Kind of a morbid tip is that when there's a chance to help, there's a chance to harm as well. You will not be the ED's favorite PE or NP if you are aggressively ordering D-dimers. It's just really important that you talk to a senior clinician in your workspace and get their take on the nightmare that can be over-aggressive D-dimer ordering.
So the big takeaway, Mike, I think for the ED is D-dimers aren't a fishing net. They're a scalpel. If you use them only after careful pre-test probability calculation, they can save time, reduce harm, and still catch dangerous clots early. If you use them indiscriminately, you're signing your patient up for a CT tour of their thorax they probably don't need.
Right. And, even, and this kind of goes along in the same respect, right? We talk about you need to do some sort of a pre-test probability, some sort of risk assessment. Does that mean that you do a Wells, you do a perk on every single person with chest pain? No. Phil Wells is on record at the MD Calc website. If you don't know it, you're going to love it. But he is interviewed on that website, and he says you can't just Wells score everybody that comes in with chest pain and shortness of breath. This is the biggest way my score gets misused. And so just as you want to be careful when you order D-dimers, you want to also be careful when you're using these guidelines that could lead you to a D-dimer. The patient's presentation is king. You really have to assess what's up with the patient, and do we really think based on their presentation that there is some sort of a PE? In the end, ACEP has some things for us, okay? ACEP says a PERC negative, low risk patient, you're done. ACEP gives us a level B recommendation on this. We can have the, ACEP, the Academy, they have our backs, that this is a good place to stop. That, by the way, how serious is that in terms of ruling out? 98% certainty. That's a very high certainty level if you have a low-risk patient for PE and they are PERC negative, 98% unlikely to have a PE. It's pretty good. When you already have a high, kind of going the other side of these things, when you have a high pretest probability, maybe they've already had PEs or DVTs before, or the story is classic. They just got off the plane from Australia, mate, and they've got one left, your right, big red swollen leg, and they're coughing up blood. Look, you just go straight to the CT scan right there. A negative D-dimer is not going to clear you when the patient, again, presentation is king, when the presentation is screaming PE, skip the D-dimer, get your creatinine and throw them in the scanner just so you can start getting clear what's going on here. Other places where D-dimers are tricky, late presentations. So if someone started having maybe PE type pain 2 weeks ago, then that's tricky because, that clot is being dissolved and the D-dimer breakdown product kind of goes down with time. So you have to be kind of careful there. Also, pregnancy, postpartum patients, their baseline D-dimer is high to begin with. So you really want to be careful there. Consider something like the years algorithm that allows you to make some modifications for pregnant patients. We're going to have, by the way, first time we mentioned this in this program, on our show notes, we're going to have links to the years algorithm and all the studies to all the papers we're talking about here. That is 2view.fireside.fm, the number 2. There we are. The number 2. Yeah, nailed it. The number 2, view.fireside.fm. Check out our show notes. Lastly, your hospitalized or very ill patients. BNP is kind of tricky. Again, if they're very ill, we can't leave that 2% on the table. We got to go chasing potentially for that PE, throw them in the scanner, and see what comes out the other side.
Yeah, Mike, I really want to talk a little bit about some case studies real quick.
Yeah.
So let's talk about case number 1, the right way to order a D-dimer. Age-adjusted window scanner TACS. So you see a 62-year-old with pleuritic chest pain and mild tachycardia. The chest x-ray is clear. The Wells is low, not PERC negative because of the tachycardia, so you order a D-dimer, and the result is 540. Using age-adjusted cutoff, 62 times 10, that's 620. This is negative. You stop. No CT. Arrange follow-up. And why is this safe? Well, you have adjust PE and ACEP-supported age adjustment thresholds in low intermediate risk adults greater than 50. That's coming from Gemme and ACEP. Yo.
Boom.
Happy 50th.
Peanut butter and jelly right there. Okay, here is a way that those units of measurement can get you a little bit sideways here. So case 2, you have a 34-year-old, 7 days postpartum patient. The woman has sudden dyspnea, pleuritic chest pain, heart rate of 128, yowzers, mild hypoxia, and understandably, you're worried about a PE. But someone jumps in there, well-meaning, and orders a D-dimer. Here's the problem. She's already higher risk based on that description, right? Postpartum, tacking along, hypoxia. Postpartum baseline D-dimers are high already and nonspecific. Now, if you're waiting on the result of that D-dimer to order that CT, you're waiting for the wrong thing because that D-dimer is not going to be able to clear this person from a PE. Let's say it's negative. But again, the patient's presentation is king. A negative D-dimer in a lady, as I described, are you still not going to order the CT because of the lab value? So what you do here is, again, you just go straight to imaging. Consider the years algorithm in case you think she may be able to escape that. But honestly, like, this is one where I would just put her in the scanner. ASAP supports this. The New England Journal of Medicine supports this. The American Thoracic Society supports this. We will, I think, have guidelines from them, or at least position papers on these actions from them in those show notes to view.fireside.fm. Further, by the way, maybe she got some sort of a DOAC or other anticoagulant because she's 7 days postpartum. You put someone in the hospital, you're often getting anticoagulation therapy. So in that case, that could push your D-dimer low. One more reason not to rely on it on these patients.
So in summary, Mike, think rule out, not rule in. D-dimer is for low intermediate risk. Skip it if it's PERC negative. Skip it if high risk. Use ASAP clarification. We'll put those in the show notes. Use modern thresholds, age-adjusted algorithms, years to reduce unnecessary CT safety. Mind the units. Check your lab. Know the landmines, anticoagulation, late presentations, pregnancy, postpartum hospitalization, all undermine the test's usefulness. And the positive doesn't really give you a diagnosis, right? So lots of non-VTE states elevated D-dimer. Interpret the context, okay? We're going to do that. Okay? All right. So I'm getting a bit silly because we're going into segment 3. And I wrote you this card, Mike. Do you know what it says?
What does it say?
What does that say to you right there?
It says, Happy 50th, Heart, MAR.
That's me. I said, Happy 50th, love me. So for the last bit of this show, we're going to go with segment 3, like normal. Okay. But we're going to end it. Oh, God, I don't even know how to say this, but the blankety blank blank stuff that keeps me up at night. And what a better topic to talk about than a sick kid. So mine is 11, still not sleeping. And I think about patients I had years ago. My God, still, here we go. The pediatric cases that keep us up at night.
That's really reassuring that you mentioned that. There are a couple of pediatric patients that I've taken care of, and you do this long enough, you remember probably less than 1% of the patients you see, but there are still a couple that I wish I could turn back time and have done things a little bit differently with these kids. Peds in the ED is like some sort of funhouse mirror. Everything looks very familiar compared to adults, but just a little bit different. Kids compensate differently, crash faster, and sometimes hide major sickness under a very adorable popsicle-stained exterior. Let's talk about 3 pediatric presentations that keep even the most experienced providers checking themselves twice.
So I'm going to start with case 1 where we take it in a little more detail, and then we're going to simplify case 2 and 3 just because we're running out of time. Okay. But I'll start with case 1, and that is the limping child.
Mm-mm.
Okay, so I talked to Emily Rose about this, by the way. So interesting stuff. A 3-year-old shows up with a limp after a mild viral illness, and parents say there was no fall, and they're afebrile, they're favoring the right leg, can bear some weight. My thought process here is the temptation to call this transient synovitis. So send them home and maybe be a hero, right? Okay, no more big tests, like whatever. But we can't miss septic arthritis. This is a surgical emergency that can destroy a joint in hours. And this is why I call upon my little friend, the Kocher criteria. Also pronounced Kocher. Kocher, Kocher criteria. It's a clinical decision tool used to help differentiate septic arthritis from transient synovitis in a child with an acutely irritable hip. It's not perfect, but it gives you probability estimates so you can decide whether to pursue aggressive workup and orthopedic consultation. So there's 4 criteria here. Fever greater than 101.3. Irritability to bear weight or refuses to walk or stand on the affected leg, an ESR greater than 40, and a serum WBC of greater than 12,000. So how do we use this in practice? Emily is right here, because we've been talking a lot about AI and AI generated differential diagnoses and plugging these things into AI. We don't have a lot of time on this show to discuss this, but a recent study that I read basically said AI is about 52% right. So nothing can replace clinical reasoning here, not even an algorithm or a guideline. So you are number one going to assess this child clinically. If the hip is irritable, get a good history, trauma, illness. Get a good physical exam, range of motion, pain location. Order your lab, CBC, ESR, CRP. This wasn't originally, I believe, the CRP in the original study, but it's now widely used for the CRP. So score the patient 1 point for each positive criteria. So you're interpreting the score. 0 criteria, they have a 0.2% chance of septic arthritis. 1 criteria, 3%. 2 criteria, 40 freaking percent. 3 criteria, 93%. 4 criteria, it's 99%, yo. Dang.
That's so hard. Like, even a 3% chance is hard for me to walk away from, frankly, because we're talking about, like, this is not a 3% chance of missing a tuft fracture, right? This is a 3% chance of missing septic arthritis in a kid, potentially a disabling disorder. So even one of these things gives me pause. There have been some relatively modern updates to these criteria. So yeah, I feel like ESR and CRP are kind of like hemoglobin and hematocrit. Like you're generally ordering both, you know? So when you add CRP to this, greater than 20 milligrams per liter can be used as a 5th criteria. In case, let's say your ESR is like meh, kind of borderline, but your CRP is way elevated, well, that's interesting. Okay, that improves accuracy. High CRP, can't walk. One of my big rules in the ER is can't walk, can't go home. And so if this kid does not have a clear trauma history, especially in the light of some sort of inflammatory marker, I'm really concerned about this. Again, go ahead.
Well, no, I was just going to say, I don't think I'm going to be able to walk after this podcast because I feel old.
Well, this is for the young, right? And so, again, it's really important. Don't replace clinical judgment. If this person looks toxic and you're low on the criteria, you don't have to discharge a child right away. Right? We all think like, hey, like, ABD, always be discharging, right? But if you've got especially a kid who's a little bit on the borderline, sometimes I've had real wins with kids by just keeping them a little bit longer than I might usually. And sometimes that extra hour or two, the disease declares itself.
Yeah, and as Emily Rose would say, who runs our pediatric course, nothing is truly sensitive and specific enough, which is why she loves medicine.
I've been looking forward to seeing Emily again, actually. I'm so curious to talk to her.
What a wonderful human being. Honest to God. Why can't everyone be just a great human being like Emily Rose? God dang it. Love her. Okay, Mike, case number 2.
Number 2, the quiet breather. We have a 6-year-old with a history of asthma, previously diagnosed with some distress. Tachypnic, speaking in short phrases, using accessory muscles. You hit her with the albuterol and ipratropium. You hit her with the oral steroids. And now she's sitting quietly, breathing more slowly, but not super happy to see you again. Not smiling, not playing well. So you're thinking to yourself, man, like if she was really better, she'd be acting more like a 6-year-old. Okay? She seems to be tiring out a bit at second glance. And here's something you consider. The way kids work in terms of their oxygen levels is they hang in there until all of a sudden they are not hanging in there anymore, and they crash hard and fast. That work of breathing is really indicative that bradypnea she may have could be very indicative of something serious going on.
Yeah, so, there's some evidence-based pearls here, Mike. The red flag is, basically dropping this respiratory rate in a previously tachypnic child, plus altered mental status or maybe more quiet of a chest. The American Academy of Pediatrics suggests to us that this is a danger zone. And pulse ox isn't enough, so look for the trends in effort, mental status, and air movement, and really this early escalation. So, let's get that IV mag, maybe some BiPAP, maybe an ICU consult of some sort. Maybe that can prevent intubation.
Yeah, I like a screaming child, honestly, right? Like if a screaming child is in my ER, that means airway, patent, breathing, going nice and fast enough, circulation to the brain is probably okay. So in peds, when a kid is quiet, it isn't always better. Sometimes it is your canary in the coal mine that something bad is around the horizon.
Right.
Around the corner. You don't go around a horizon. You go over the horizon, around the corner. Sorry, I had to correct that.
I felt you with my twingy eye on the video. Last case, Mike, and then we're going to wrap things up for today because I'm beat. It's been an hour. Okay, so case number 3, the pink but perilous newborn. So this is a 5-day-old infant who presents with poor feeding and intermittent tachypnea. On arrival, they're pink, they're warm, they're satine, 98%. And the sorry, I laughed. That was really inappropriate. The triage note reads, I can't even read this out loud, but it's
not flu-like symptoms. That's not what it says.
Literally the triage note says probably viral. I just stop that. Stop it. So the thought process is, okay, it's like you don't have to believe that. Just go in and assess the patient. It's cool that you do that. So in the first week of life, some congenital heart lesions, especially, gosh darn it, these duct-dependent lesions are still being held together by, what did I just teach in lecture last week? But the PDA. By the way, Mike, I had to teach pediatric cardiac defects, and I literally, my brain hurt after it. But it's so structurally, how can I say this? Once you understand pediatric defects, and this is what I told my students, you get it. You understand it. If you know what the left side of the heart does and the right side of the heart does, and then you put it together and you think about these shunts and fetal to newborn heart activity, it's not complicated. And they all got mad at me because I was like, listen, guys, this isn't a brain. It's a heart. It's not complicated. They were like, screw you, Professor Roberts. This is hard. And I'm like, no, just draw yourself a picture. Anyway, I'm totally moving in another direction. But the thought process is, in the first weeks of life, like we said, congenital heart lesions, especially duct-dependent lesions, are still being held together by the PDA. As the duct closes, catastrophic cardiovascular collapse can happen fast.
Yeah, I know what you mean. I just had a patient the other day who had a potential hematologic emergency, and I'm still recovering from that. Yeah, blood's hard, y'all. I don't know if you knew that. Blood's hard. But yeah, I totally agree. It's really helpful to know the heart. I think of the heart as, it's got two halves, two ways. You've got a left and a right, you've got an upper and a lower. And once you understand there's plumbing, there's wiring, there's carpentry, the heart is a really neat thing. And it makes sense. The heart makes sense. It really does. So to that end, some evidence-based pearls. If you see a newborn who is having poor feeding, tachypnea you can't explain, which is tricky to begin with, right? Try counting respirations on an adult. It's even harder on a kiddo, but it's important for these 5-day-olds, right? Poor feeding, unexplained tachypnea. You maybe feel a bigger liver than you'd expect on this child, or maybe you check the pulses, brachial pulses, lower extremity pulses, and you feel some kind of pulse deficit. It's not enough to feel one pulse. You got to feel a couple and see top to bottom, left to right, are there some pulse deficits? Look for those things and consult your favorite pediatrician. Next, there is such a thing called the hyperoxia test. This is not foolproof to understand the presence of a duct-dependent lesion. Echo is king. I teach board review, and it's almost tiring because you're like, okay, so you have this valvular heart disorder. The gold standard diagnosis is echo. And everything is echo, right? When it comes to these valvular, these plumbing issues, echo is the winner here. And so you may have to keep the patient for an echo, transfer the patient for an echo, a patient this young with tachypnea, poor feeding, etc.
Or keep the PDA open.
That's right. And you would do that by giving a prostaglandin E1 infusion, of course, to keep that duct open before you transfer them. So that's one of those things where if you have somebody who has a duct-dependent lesion and you think they're in the middle of it closing, you can, just like you would give antibiotics for a questionable meningitis. You could give prostaglandins for a questionable duct-dependent lesion before you put them on the ambulance to kind of keep it open during transport.
Yeah, and if you're not really good at this stuff, which, by the way, I don't expect you to be, the listener, because lots of my pediatric friends do review this stuff. Review it. Go over your heart defects, your acyanotic and your cyanotic heart defects, and how those patients present. So the ED takeaway here is never be reassured solely by pink skin in a newborn. Circulation can be balanced on a knife's edge.
We can't just chalk misses up here to zebras. These are horses when we're dealing with newborns, and they're why sometimes PD patients can feel a little bit dangerous. If you stay alert to the limp that's more than transient synovitis, the asthmatic who's getting more quiet than loud, and the newborn who's just a little too perfect, you'll catch the life-threatening stuff before it catches you.
Well said, Mike. Wow. Well, that's it. We're done. That's episode 50. I can't believe it. What a better way to end this show with something free. Free courses.
What'll it cost?
Nothing. Free.
Oh. Well, let's start off with our 2-view trivia question from the last episode. It was this: what is the etymology of the term hepatitis? And scientists from which country are considered to have discovered hepatitis C in 2005. Hepatitis is a medical term with Greek roots, hepar, meaning liver, and itis, meaning inflammation. Hep C was first, quote, discovered in 2005 by a Japanese team of scientists. And we have a winner here, Martha. Go ahead with the winner.
So excited. Simran Disabar from California, nurse practitioner, newly minted. She got this one right.
That's awesome.
Congrats.
Does she still have the minty smell to her if she's newly minted?
Honestly, she's very fresh. You know?
Very well.
Anyway.
Do you want to read the next trivia question for this episode?
I do. So the new question is, PJ Gaffney is considered
one of the
most influential discoverers of the D-dimer. In what year did he first publish his findings about degradation products of cross-linked fibrin, and who was his co-author? Sweet.
Email us your 2-part answer in addition to anyone you want to give a shout out to, as well as any feedback or comments about any of our 50 episodes to 2viewcast@gmail.com. That's the number 2viewcast@gmail.com. More information on the original and advanced emergency medicine boot camps, the emergency medicine and acute care course, or any of our courses, more every day, I feel like, are available at the Center for Medical Education website. That's www.ccme.org, www.ccme.org.
New and upcoming courses will be announced for 2026, so keep checking back. We've got some new stuff on the burner. And also try to attend one of our already stellar courses, including our original boot camp coming up in November.
Whether you are a first-time listener or a day one homie, thank you for listening and attending this episode of The Two View. You can subscribe and rate us on Apple iTunes Podcasts and Spotify, YouTube Music as well. Search for 2View Emergency. That's the number 2View Emergency. It'll come right up. Ratings help us climb the charts so that other clinicians get some 2View goodness just like you have for 50 episodes in a row. If you like YouTube and you want to see Martha's impressive sign that she wrote me or the balloon that she demonstrated, search for Center for Medical Education on YouTube and you can catch the video version. Don't forget that website where you can go next level on any of our topics from any of our 50 nifty episodes, including all the papers and sites we referred to. That's 2view.fireside.fm. Our audio and video engineers are Ricky Bucata and Dave Pett.
Special thanks to Dave Pett this month for his audio engineering major skills and how much work he's been doing. So thanks again for tuning in, friends in EM. Share this podcast with a friend. Share your thoughts via email. And thanks again for sharing your time with us today on The Two of You. Have a good day and a great shift, Mike. Happy 50th. Love you so much.
Love you, Mar.
Take it easy, bro.